Welcome to the American Shoulder and Elbow Surgeons Podcast. I'm your host, Peter Chalmers, a shoulder and elbow surgeon at the University of Utah in Salt Lake City. Before we get started, I should mention the views expressed in this podcast do not necessarily reflect the views of the American Shoulder and Elbow Surgeons Society, the University of Utah, or the institutions of any of our guests. Today we have an episode on a controversial pathology within shoulder and elbow surgery, which is the evaluation and management of acromioclavicular injuries, i.e. shoulder separations. So to discuss, we've invited two nationally recognized experts. First, from the Mayo Clinic in Arizona, we have Dr. JT Tokish. JT, welcome to the podcast. And then next, from Mass General in Boston, we have Dr. Gus Mazzocca. Gus, welcome to the podcast.
Thank you, Pete. Glad to be here.
Well, I'm very excited to have you both on the podcast. I know this is a subject of interest to both of you, and I want to start at the beginning. So just pretend a patient comes to your clinic, they've got a shoulder separation. Before we get to examine imaging, are there any aspects of the history that are relevant? So is there anything the patient can tell you about their story that's useful to you in the evaluation of this patient? JT, tell us what you think.
Well, normally these guys are traumatic, and so they usually there's a story of the injury that's kind of comes in with that patient. My background was what I learned about with this injury was I took care of military athletes for an awfully long time, and so this was super common for us to see with guys coming in with so-called ear ticklers. Where they, get out and they're doing either unarmed combat or they're falling with weapons training, et cetera. So it was a really common condition in our population. I will say that my views on this whole thing were tempered in my fellowship with Rich Hawkins, who always referred to the AC joint injury or the AC joint operation as an operation waiting to fail. So I guess that's from the beginning where I gained a healthy respect for these.
What are your thoughts, Gus? Is it when you approach this patient, are there aspects of the history that are relevant to how you proceed with treatment, or no?
I would say that the history in a shoulder patient is always important because you're also looking for other possible injuries or other pathologies that may be causing the pain, especially when something's obvious, say in a grade 3 or a grade 5, where there's, obvious deformity. Sometimes there's other things that can be driving the pain. And as JT talked about, instead of spending a lot of time fixing the AC joint, you can fix something else that may be causing the pain and, not go with the obvious. So I think always trying to take a good history and figure out what exactly happened and how, but I would not say that I'm looking for anything specific like we do for, say, shoulder instability.
Okay, so you've taken your history, you've confirmed that this is isolated, the pain is not coming from something else. You're going to go to examine the patient. Let's hear from you, Gus. What are the important aspects of the exam here? Does it matter if it's reducible? Does it matter if they can get full passive elevation? What do you think is important in terms of exam?
Yeah, so I start out always, with a C-spine exam. Make sure that I can see the, the shoulder itself. Take the shirt off. Make sure that I have good visualization of both sides. And then, we start off with active range of motion. Depending on how acute you see them or how soon you're seeing them, that can differ a lot. And then I'll just follow with passive range of motion at that point. I will then really try to look at the scapula and if or how they're trying to control the scapula. That can change a lot. If you see, say, an athlete, the day after an injury or, after the game, their scapula can look completely different a few days later, which is, if they can control it, then they're going to be able to handle that injury a little bit better. Then I look for obvious, palpation of that painful area. And then what I'll try to do is go to the non-injured shoulder and look by stabilizing the scapula with my index finger and thumb on the acromion and the spine of the scapula. I'll try to move the scapula horizontally and see what kind of play it has on the good side, and then see what kind of play it has on the injured side. And then I'll have them shrug their shoulders and do that shrug test that Dr. Bach taught me. And if they can reduce when they shrug their shoulders, then to me, that's a grade 3. And if they can't reduce it, then it's a grade 5. Then I look for the patient that has kind of more splinting and tremendous more pain, can't really move. And at that time, I'm suspicious for a grade 4, and I'll try to palpate and see what they have posteriorly, trying to determine if it's penetrated through the trapezius fascia for a grade 4. I think 1s and 2s really just have pain, and they don't have a lot of horizontal instability. And that's kind of how I assess that one specific part of it. We'll definitely do strength exam to make sure their rotator cuffs intact, make sure they're neurovascularly intact, and then, look for other things as they, depending on when you examine them and how they feel.
What are your thoughts, JT?
Yeah, I guess I've become a little jaded over the years with the physical exam, and here's why. When the patient comes in to me, often they come in for one of two reasons. Either they came in and it's fairly acute, in which case they are so painful that I can't trust anything on them, right? So Ben Kibler talks about, I think this is valuable, if they can reduce it by putting their scapula into a retracted position and a posterior tilted position. It's Ben's opinion that if a patient can do that, then they're going to respond pretty well to conservative management over time. I think that's valuable, although it's not studied in the literature very well. If that patient has good control of that, that's pretty good. So the first thing is that if it's acute, that patient comes in and they're really hot, I don't know that there's a lot I can tell on exam tremendously. So I usually will let them cool off for a little time and then get an exam when they're a little less fired up. The second reason that patients often come in to see us is because they don't like the way it looks, right? And so I kind of cut to the chase over the years. I say right up front, listen, if you don't like the way this looks, we're going to have to do something to fix it, because nothing that I know of will make this go away completely. But if this is a pain and functional issue, well, let's give this 3 or 4 weeks and let it calm down. Let you kind of this is going to feel a lot better 6 weeks from now, 4 weeks from now, and then come back and then let's see where you are and make a decision from there.
I think that's well stated, but I think in the athletic patient that needs to try to get back or play, you have less time. So I think for kind of the weekend warriors or mountain bikers or something like that's a great strategy. But I think there's a little bit more urgency in the athletic population.
Oh, sure. I would agree with that. Although if it's an athletic population and we're moving on to treatment, I would tell you that I would tell all these guys, if you feel like you can play, you can play. And if you can't play, I'll inject you and we'll try to get you to play. So the physical exam, I don't know, for me, doesn't make a decision on play or not play. That really becomes a situation of, hey, are you functional enough where you can can you protect yourself, et cetera, kind of going forward.
Let's talk imaging. So patient comes in, is this your standard 4 views? Are you getting a Zanka view? Are you getting an Alexander view? Do these help you make a decision? Yes, no. What are your thoughts, Gus?
I get a bilateral Zanka view. That really tells me probably just the most obvious. I can see the uninjured side and the injured side. I really look at the corticoclavicular distance, and I also look at the acromioclavicular distance. To the next, probably most important image for me would be an axillary view, just making sure there's no other injuries, coracoid fractures, lateral clavicle fractures, that kind of thing. Those are probably the 2 biggies that I really spend the most time looking at. We'll, of course, get the complete, Grashy view and then an SOV view. We were using that Alexander or Bassmania view, but I haven't found that helps me that much. And it's kind of hard with in our office where there's various x-ray techs, depending on the day, to try to delay and go through that and have them do it, and it hasn't been that helpful. So if I can get a good bilateral Zanca and an axillary view, then I feel pretty good.
What about you, JT?
Yeah, so I think I've learned a lot about this over the years. I totally agree with Gus that, you know, coming up, and Carl Basmania was a longtime practitioner in the Army, saw a lot of Special Forces guys, has a ton of experience with AC joints. So he found that test very helpful for him. He felt it was helpful to discern between stable and unstable shoulders. So if you get that cross-body view and it slides under, the suggestion is the scapula is protracted in internal rotation, and there's a kind of a, I don't know whether it's an urban legend out there, but if that's the case, that becomes unstable and you should fix that. But I've gone to the literature several times to see if I could find any evidence on that, and if it's there, I've missed it. I can't find it to where it's predictive of either outcome with non-op or the need to go forward with surgery. So it hasn't in practice been helpful for me. And again, a lot of times those patients are too painful for them to actually even get over it. And so then you say, well, is it because they're limited by pain or because they can't get into the position? So that one hasn't been tremendously helpful for me. The other one that we've learned about, and this is a paper that we did with a young man named Kevin Krull, who published this with us, and we were trying to figure out how to determine these, because in truth, we found that a lot, just like Gus was saying, depending on the X-ray tech and how controlled you can make these imaging systems, we found there's a ton of variability in the CC distance or the relationship between the AC joint, just because of rotation and because of different views and different angles on this thing. And so what we found was, at least in a predictive study that was published a few years ago with Kevin, was that that a single shoulder, and the short answer to your question, I get the bilateral views just like Gus does, but we also get a single straight gray AP view. And what we found there was the most predictive, the only thing that was real predictive is whether that CC distance on that view, which we were pretty accurate with, was greater than 20 or less than 20. And if it was less than 20, those patients tended to do very well with non-operative management. If it was greater than 20, they didn't do very well at all.
Is there any role at all for non-operative treatment? I'm sorry, for an MRI to determine whether non-operative treatment is appropriate. So here's my question. You've gotten your X-ray views. You think it's kind of maybe borderline, and we'll get to whether or not you treat this surgically. I just want to ask before we get there, is an MRI helpful to look at delta trapezial fascia, to look at the status of the ligaments? Is there ever a situation in which you're ordering an MRI for a reason other than to exclude other pathology? What do you think, JT?
Well, yeah, I think you hit it on the head. To exclude other pathology, I think, is critical, because, as you know, there's studies that show that there is a significant portion of injury with this, whether it's superior labrum or cuff damage, et cetera, that you might want to consider looking at. But if I throw that out, as you made clear, if you said, hey, we're going to not look for that, what else would you get on MRI? Honestly, for me, there's not a lot of role for additional imaging beyond that.
What do you think, Gus?
I agree.
All right, so let's talk non-operative treatment. The patient comes in, let's pretend it's acute injury. They'd come to you, 3 days post-injury. You've decided to proceed with non-operative treatment. What does that look like for you, Gus? Like, what are you telling the patient that the next 3 months is going to look like? What are they going to be doing? What do you think that you would do for that patient in that situation?
Yeah, that depends on a lot on the individual patient, what they're, what they're doing. Are they an athlete in season? Are they athlete out of season? There's a lot of it's got almost the same variability as almost a shoulder dislocation for me. So everybody's different. A 55-year-old with a shoulder dislocation completely different than a 16-year-old that's out of season compared to an 18-year-old. So I think for me, I would say that I default to non-operative management until they fail. I tell patients they can get back to work and get back to sports much quicker if I don't do an operation. And then what I'll do is see them 2 weeks or 4 weeks, depending on, if they're in the office. If we're in the training room, then obviously the It's significantly, accelerated at that point, like JT was talking about. If they want to get back and think they can back and they have range of motion and strength and they just still have some nagging pain, then injection is fine. But I would say my spiel when I first see those patients is, we can get you back doing the things you want to do much quicker without an operation than with an operation.
What about you, JT?
Yeah, I agree with that. And I would, the only caveat I would say is that for me, that is also true of the grade 5. So it doesn't matter to me whether you're a grade 3 or a grade 5, and we'll get into why I feel that strongly about that. But that initial thing, the first question is to say, does the cosmetics of it when you look in the mirror, is that going to bother you? And if it does not bother you, if it does bother you, then I don't have a way of fixing you except for an operation. So we should plan for that. If the cosmetics of it is not important to you, and having a little bump, and you may change a little as the swelling goes down, et cetera, but that bump is going to persist. And I'd say if the bump doesn't bother you, then I would say in my hands, I don't believe there's any advantage to jumping on this right now, and you're going to feel a lot better. So everyone would be managed non-operatively, provided they don't have a skin compromise or the mythical unicorns grade 6, right? Or something along those lines, but within reason between the 1s, 2s, 3s, and 5s, for me, those are all managed non-operatively unless I'm pushed.
Do you agree with that, Gus? Would you say that there's really no one who should be treated acutely surgically, excluding obviously those rare cases?
I think the word should is probably not ideal, Pete. I think everybody is different, and I think surgeons and providers are all different too. So if there's a procedure for the AC joint that can reproducibly eliminate that bump and doesn't, quote, settle anymore, I think we would do far more of these, because I don't think anybody really ever likes the bump. But I think the fact of them getting back to doing whatever they want to do a lot of time overrides that. I don't know, should. I know there's a lot of people that, we did a meta-analysis with Knut Beitzel where acute versus chronic, we looked at in the literature. Our orthopedic literature, especially for AC, is not great. And we don't have a heck of a lot of data on non-operative treatment of AC joints. But we didn't find any kind of significant difference between acute or chronic. But there was a trend that some of the acutes, had a tendency to do better, although that was kind of faulted. Some of that data that we had was a little faulted and biased. So it's hard to say. I say should. I think the surgeon and the patient make a decision, and then they go for it, whether they want to do an acute operation, whether they want to do an arthroscopic procedure or an open procedure or what. I tell patients that the procedure I do is the same procedure if I do it 4 weeks or 4 years.
So that's interesting to me. So the patient comes in acutely. Let's pretend it's only been a week. You're seeing the patient a week out from surgery. You have time tomorrow in your surgery schedule. You're going to fix them tomorrow. Again, let's leave aside. Let's pretend you've decided to fix it. You and the patient, that's what you both want. Are you still adding a graft in the patient that's only a 1 week from injury? And if so, is that necessary? I'm curious to hear both of your thoughts on this.
Well, I'll let GT go first, because I have I'm not in that situation. So.
Yeah, I'm happy to speak with it. I will say that yes, I do a graft in 100% of cases. Every AC joint for me is the same operation, chronic or acute. And there are several reasons for that. I suppose there is the case where you have a perfect avulsion of the AC joint off of the coracoid or off of the clavicle, and you put a tight rope or whatever device it is that you're going to be as kind of an internal splint, because that's what it's going to work as, but it's never going to heal. So I suppose you can, and certainly people have, hit the home run by putting a tight rope or whatever device you want to do to put that down. But if you're not lucky and you don't put those ligament fibers exactly in the right spot, or they don't line up exactly in the right spot, it's never made any sense to me why we would expect that to heal in a strong way. And I think the literature actually supports that. If you take a look at data that has been even as recently as 2023 out of Korea, when they look at acute reconstructions of these things with no graft, you're often looking at a failure rate in the 30s. And so I think, thanks to Gus, honestly, and work from him, I think that our failure rates have come way down below that if we follow a concept that says, look, we're going to do everything, and we'll get into exactly what that is, I'm sure, later, but everything includes a graft and internal brace and everything else, again, trying to flip the coin on that operation and trying to fail.
Gus, same
Peter,
thing.
I think failure, sorry to interrupt. I think failure, though, I think we should define failure. Failure meaning the patient after the operation is in so much pain that they get a revision, which I think is incredibly rare, versus failure meaning the CC distance and the AC distance slowly, quote, settle over time. And it's not where you put it when you did the operation, but it's not bad.
Okay, so I think we're at the point now where we should talk technique. I would like to hear from both of you. What is your current state of the art? And JT, it sounds like this is the everything approach, and I'd love to hear what the everything is. And what does the technique look like? And maybe you could just go through the bullet points for us, Gus, of maybe go first. Tell us what the approach looks like for you.
The approach for me is beach chair position, probably a little bit more straight up than down, because I like to be able to get to the back as well as the front. I use a mini C-arm, and I look before we prep. I'll try to get a good, what I consider a Zanka view, or a good view of the coracoid, clavicle, and acromion. And then I'll manipulate that scapula to see what I have for instability and how I can reduce it. Oftentimes by, as JT talked about in the physical exam, just by moving we used to, in the old days, lift up on the arm. That was our big move. But you can reduce an AC joint just by manipulating the scapula. So you can take a, quote, grade 5 or a grade 3, moving the scapula, especially if it's relatively fresh, and can see that it reduces. There are others that don't, but that gives me a little bit of information. Then I do a kind of a saber incision from the tip of the coracoid up over into or at around the area of the trap. I shade that a little bit more medial, so I'm not doing it right over the AC joint, but probably 20 millimeters medial. And then we'll develop that plane. So now I can see the trap coming down, inserting into the AC and the clavicle posteriorly, the deltoid inserting anteriorly. And then I'll try to find that the line between those two muscles, and I'll make my incision with a scalpel and a bovie, because a lot of times it's vascular, which is good. And then as I get over to the AC joint, what I try to do is really take that incision and shade it more posteriorly. A lot of times, if I go straight across, I start to run out of tissue anteriorly. So I'm very cognizant of that, and I'll try to go through the mid portion of the AC joint. But if I'm going to err, I'm going to err more posterior on that AC joint, so I have more tissue anteriorly. Once I have that, then what I'll do is I'll peel off, as a kind of a whole tissue sleeve, the anterior. The deltoid has 3 insertions on the clavicle, superiorly, anteriorly, and inferiorly. So what I'll do is I'll try to peel off from the acromion going medial, the deltoid, making sure that I don't use bovie as much as I do, like with a little elevator or a half-inch curved osteotome, to try to take all that tissue off in total, making sure that I have both the superior, anterior, and inferior. Once I have that off, you can drop right down onto the coracoid process. What I'll do at that point is I'll walk my way to the tip of the coracoid process. Oftentimes, it seems as if the clavicle, which doesn't really move in that situation, but because of the position of the scapula, it appears that it's more posterior. So if you just start trying to go around the coracoid at that point, sometimes you're too posterior and you can start to run into issues with the suprascapular nerve. So I'll work hard to get to the tip of the coracoid. And then from that point, then we'll try to develop from the medial side of the coracoid and the lateral side of the coracoid. And that's kind of my approach to kind of set that up. I'll usually use a PDS to try to sew or, make sure I have my deltoid in a good position and good control of that. That's my approach to then start to do all the other things that we're going to do.
Okay, JT, does that differ from your approach? Are you taking an arthroscopic approach? Is there any benefit to the arthroscopic approach?
Yeah, mine is a little different from that. First of all, I'll just tell you that all of us have sat at the feet of Gus in terms of what he taught us about the anatomic approach to this. I mean, it should not go unnoticed that this whole thing started. He changed everything. And listen to this. He, as you guys know, or Gus certainly knows, he dissected 120 clavicles for anatomy in a paper with, I think it was Rios back in the day. And what they found was that the acromioclavicular ligament anatomy, which had not yet been really well defined, this is Gus's work, he found that it was very consistent in terms of the ratio from the lateral edge, 17% for the trapezoid ligament, about 30% for the medial border of the conoid. So the point is that that was very, very reproducible. One of the things we learned, though, was that that ratio is very good, but you can't translate that to a number. And one of the big sort of eureka moments that we had with this was, depending on the size of our patient, if you use the ratios, that would translate into up to 9 millimeters of difference in where you put your tunnels. And so we said, gosh, we're going to cling to what Gus taught us about where to put it. And so we began, we went back and looked at a bunch of ours that we had done, and we compared failures to non-failures and how close we were. And here's what we found, which was, for me, it was the day the light went off. When we were lateralized, i.e. when we put especially our conoid tunnel, if it was less than the 25% distance from the end of the clavicle, so less than a fourth of the way home, we didn't see a failure, not one. When we were greater than 30%, we didn't see a success. All of them failed. And in between, it was in between. So that was the day we said, oh my goodness, it's anatomy, right? And so from that day forward, including to today, I begin with templating every single AC joint that I do. And I put those tunnels exactly where Gus taught me to put them, which is, for me, 0.17 for the trap and 0.25 for the conoid. Okay, so now I know where to put them. So now I start with a scope. And I'm sorry, I don't start with a scope. I start with a straight incision that is 4 centimeters from the edge of the AC joint over toward medial to the clavicle. And it's just subcutaneous, straight one like you would do a clavicle fracture. And the reason is I dissect out the AC joint every time. The reason I do that is because if you don't get that disc, sometimes you can have a block to reduction. And that's one of those don't ask me how I know that kind of things. So I make sure that I can get the top of that clavicle absolutely flush with the top of the acromion. And it takes a little bit to dissect that out. So I make sure my incision includes that. Then I'm going to go 4 centimeters medial to that so that I can get down center on the bone. And just as Gus mentioned, it's critical that you can elevate that anterior aspect of the deltoid all the way off the clavicle. And in fact, I go all the way under it because we're going to be drilling tunnels. Once I've got that, I stop for a second. I'm in the beach chair position just like he is. It's the only procedure other than arthroplasty that I do in the beach chair position. But I still like to do this in the beach chair position. And so what I'll then do is stick the scope in, and then I'll open the interval. And then through the interval, I can see the medial border of the coracoid. And then through that little incision where I am medially, I take a switching stick and I go down and I palpate the coracoid. It's very easy to do. And then I just slide down on the medial side and I'm looking at it through the camera. And then you take one of the metal cannulated things that you introduce your cannulas with, so the metal one, like the dilator, and you put that down over the top of your switching stick. When you can visualize that, which is pretty easy to do, you're viewing from the back and you can see it right medial to the coracoid. You remove the switching stick and you just put a little fiber stick or a passing stitch. Now you've got access to the medial side of your clavicle. That's it. Then you just retract that out your anterior portal and you pass it lateral to the coracoid, which is easy to do. And now you've got it around the coracoid. My graft is always a graft, so it's always at least a semitendinosus that's of about 6 millimeters in diameter. And then I do a double internal brace. So from the middle, I'll take a fiber loop or some sort of looped suture, and I'll run from the middle out to the periphery on one side, and from the middle and out to the periphery on the other side. So the whole thing looks like a Roman sandal. That's my first internal brace. And then I run a fiber tape along with that. That's my second internal brace. I pass those using the stitch that I just had. So now we've got the clavicle or the coracoid taken care of. Then you just pass those through 2 5-millimeter tunnels. I'll drill 5.5 millimeter tunnels in the clavicle at the spots that I mentioned earlier and before. And then the graft comes through those tunnels. I then reduce it using that same metal introducer on the clavicle, and as Gus mentioned, lifting up the scapula via the elbow so that I've got a really good reduction. And then when I'm there, I tie down the first internal brace. Then I make sure that the length of the graft is long enough to be able to reach the AC joint. And then I put my 2 PEEK, not biocomposite, not biologic, PEEK interference screws into the 2 tunnels and fix those guys with enough length so that the limbs of the anchor or limbs of the graft can get out to the AC joint. And then I reconstruct the AC joint. And then I do as deep and aggressive a job on the clavipectoral fascia as I can. And that completes the operation.
Any alterations to that, Gus?
Yeah, I would say that we've really struggled with the protraction, retraction of the scapula around the clavicle, which is really a strut. And I think that really is what leads to the settling that we found. So what we've gone to is using a small metal anchor at the end. We fix and reconstruct the AC ligaments like JT spoke about. But instead of what we used to do, which is sew the deltotrapezial fascia back together over the top, I take a PDS and kind of run it on those 3 areas of the deltoid I talked about, superior, anterior, and inferior. And then what we'll do is, as we have that kind of as a whip or a baseball stitch, then I'll take a micro metal anchor as small as I can and put that into the area of the lateral clavicle. It's double loaded. And then what we'll do is we'll tie 2 horizontal mattresses trying to reinforce or have that deltoid attach right to the anterior AC ligaments. If when we opened up that AC joint like JT did such a great job describing, posteriorly, we'll do the same thing with a small anchor and then take that trap and attach that to the posterior aspect of that AC ligament. And we biomechanically were able to mitigate some of that protraction, retraction, or perceived rotation. So there's a significant amount of superior, inferior, which, a lot of the devices that have been mentioned in the graphs can take care of, right? That's the conoid and trapezoid. By reconstructing and also imbricating the AC ligaments, you can also mitigate a lot of the horizontal or anterior to posterior motion. But all of the different ways we had to try to fix that AC, which is, a round dowel into a flat plate, becomes hard. And that's why we started looking at the last part of it, which was that deltotrapezial area. And that's why we try to reconstruct that now, not over the top, but into that AC ligament to try to help with that horizontal motion, as they did start to mitigate that a little bit as well. So that's kind of where we're at now.
Let's talk grafts. So allo, auto, hamstring. What's your preferred graft, Gus?
I would say I used to be a big semitendinosis, but semitendinosis can be hard to get sometimes, and I don't think it really matters. So we use peroneus longus. We just need a piece of collagen that we're going to be able to, as JT talked about, reconstruct our conoid, reconstruct our trapezoid with those peak interference screws, and then try to really work on those other two things, which is the AC, imbricating it, reconstructing it with the excess graft, and then talking about trying to repair the deltotrapezial, deltoid to the anterior, trapezoid to the posterior.
What are your thoughts, JT?
Yeah, I'm naturally inclined toward autograft, but it's interesting, nobody ever complains of graft or donor site morbidity when you do a hamstring ACL of their hamstring, but they sure as heck complain of hamstring donor site morbidity when you take it for anything else, right? We've all seen that. I would say that we looked at our own series of this at Tripler with Jay Cook, who was one of our residents at the time, an outstanding orthopedic surgeon, and looked at the difference, and we didn't find a difference between it. Looked in the literature. There's not a lot out there, but the studies that are out there, I don't think guide us toward one being better than the other. So I think allo and auto are the same. It's certainly faster, no chance of donor site morbidity. As to the type of graft, I agree. I don't think it matters very much. I don't think you want to put a hog in there. I don't think you need to put an Achilles tendon or something like that. But so we usually use semi-T, but a posterior tib and trim that down a little bit, or a peroneus longus is fine by me too.
All right, so it's beautiful description of the technique. I think listeners are going to get a ton out of that alone. A couple more questions for you guys. When, if ever, do you use a hook plate? Is there ever a situation that warrants that? What are your thoughts, JT?
Yeah, revision situations, I will often use a hook plate. They work. The challenge is that they work while they're in, and they need to come out. And I've got a bunch of guys that disappeared back to Okinawa or went back to Guam or wherever they were in the Pacific and quote unquote forgot. And I've seen a couple of those what they eroded through, et cetera. So you have to have a patient that buys in to say, yep, we definitely need to take this out. And then I do think it adds as a real protector of this. So in revision cases, it's a good one for me. I do not do it as a standalone procedure ever.
What do you think, Gus?
Yeah, I agree. The one way we kind of get around that is, if you're going to do it, I think the other time that it's been helpful is if you have a instability and pain due to too aggressive distal clavicle excision. And at that time, or some type of, malunion or non-union, I think the hook plate can then be helpful at that point to stabilize things, let things scar in and heal. But then scheduling the hook plate removal, so that it's on the books as opposed to letting them come back and then decide. Even if you have to delay it, at least you have it there and it's in the patient's mind that they're going to get it removed.
Okay, so you've done the beautiful operation you just described. It's in an athlete. How long until they can return to play? Let's pretend it's a football player. It's like someone contact collision athlete. How long to return to play? What do you think, Gus?
I think they're all the same at that point. Once we have that graft in there, we'll put them in kind of not a sling, but some type of unloading device. 70 newtons comes off, hangs off of what we just reconstructed with, dead tissue and a couple of little tiny sutures. The one thing I will add, though, is, which I didn't describe in that technique, is I use, a specific company's cerclage tape. So I'll go around the coracoid, but then through the cannulated portion of the interference screw medially. Paul Cagle kind of taught me this trick. And then we put that knot between the clavicle and the coracoid. So we kind of retro place that suture around. And that's kind of what our first, that's how we reduce it on the medial side for the conoid. And then we cycle it and put in the trapezoid side. But with that being said, I'll put them in like a Lerman brace, some type of unloader so that their arm is supported, not hanging, but always supported, almost like they're, contracting their traps or kind of hunched a little bit. So that arm is completely unloaded for 6 weeks. And then we'll take them out of that. We'll take bilateral Zancas to see where they're at. Then we start range of motion. You can actually tell who's been compliant and who's not based on their range of motion right at that point.
For sure.
They're worried about that. If they don't have it, I say we never went in the glenohumeral joint, so you'll be okay. And they get their motion by 12 weeks. We start them strengthening at 12 weeks, and around 5 months, if they're, have full motion, good strength, and feel great, then we can let them go back. And if they're still struggling at that time, then we send them back to, work or labor camp at 6 months.
What are your thoughts, JT? How long to return to play?
Yeah, pretty similar. I'm slow. I'll take every bit of it that I can get. Right. I don't trust that thing at all, and I don't trust it even at 5 months. So if that's when season starts, then we'll bite the bullet a little bit. But I usually tell my patients 6 months if they have it. I don't hurry. I do similar stuff to Gus in terms of post-op rehab. I would say for us, this is a standard shoulder with the abduction pillow, except that the abduction pillow, and we've talked to a couple companies about putting the Velcro in a different place, and here's what it means. Everybody gets the pillow, and then they put the arm on the outside of that, and that helps you stay in abduction. But what I tell the patients is we want to take that Velcro off the abduction side of that and actually put the elbow on top of the pillow. So you've got that natural rest. It's an arm rest, essentially, like your car. And so I tell them I want the arm as an armrest almost 24/7 for the first 6 weeks. Again, an operation waiting to fail. And so when they and that's really the only thing I do. When we begin range of motion, I don't mind them starting at 6 weeks. But the one thing I tell them is, at 6 weeks you've got a heavy arm. Do all of your motion supine. So we really do that to take gravity out. And there's no pressure of trying to take that arm and get it to fall. So I say, look, I want you to get full forward elevation here now, and let's get after it, but only in the supine position, so we're not fighting weight and gravity. And most of the time, if these guys are going to fail, they fail early. They fail in that first 6 to 8 to 12 weeks. And so if we get them through to that, then it's usually pretty good.
Let's talk for a second about failure. You mentioned earlier, JT, that there's a literature suggests a 30% failure rate. Obviously, you guys have done a ton of work here to improve this. With your current technique, with your current rehab protocols, what do you think is the chance of success of maintenance or reduction, i.e. that you get an x-ray at 6 months, at 1 year, and it's equivalent side to side? What do you think, JT?
I would, just a little bit misleading. I would say that it's probably 1 in 10. It's probably 90%, but I will caveat that I'm not looking after Army Rangers anymore, right? So my population at Mayo, I'm just as likely to have a 45-year-old guy who's a recreational athlete who can take time off and is not going to push things so hard. So I think it would be a little arrogant for me to say, oh yeah, I got this thing figured out. I'm not sure that I do, but I would say that that our results from a radiographic standpoint, we radiograph everybody. It's pretty uncommon for us to see a failure now. And I will say that when we started on this journey, I'd say back in 2010 or 2011, I was probably, if you just go strictly on radiographics, I was probably in that low 30s, high 20s, low 30s kind of, loss of a little bit of that reduction kind of going forward. So very, very pleased about where we're going. Certainly not perfect, but much improved with much of the techniques as they've been developed.
Do you get those numbers, Gus?
No, mine are much worse. I would say that, we get, like I said, we get that bilateral Zanca view at 6 weeks. We get another one at 12 weeks. We get another one at 6 months. We get another one at a year. And I would say that at 2 years, I would say that I don't think, maybe I just dwell on all of these too much, but I don't think I've had one that stayed in exactly the same place.
Maybe you should stop getting x-rays, buddy.
That's what Dr. Andrews taught me.
Yeah.
He admonished me one time for that, and that's true. If you stop getting X-rays, then they look good. You're right.
Yeah, we get them through 3 months, and that's it. And you may be well right. But I guess I don't see many patients who come back. I don't know. That's another way to define failure. How many times do you see those patients that come back and say, "Hey, this thing is up, and it didn't work"? Is that common for you?
No. That's why I brought up the whole failure thing earlier, right? Like I tell people that, hey, you're going to still have a little bit of a bump at about a year. Like, you're still going to have a bump. So if the bump's the big deal and you think it's going to go back to normal, then you need to see one of my partners or some of my competitors or whatever, because I'm not going to be able to do that for you. I have not, or very rarely have I done a revision because the patient has failed and has persistent pain. So, when I'm radiographic failure, absolutely doesn't equal, clinical failure. So I've done very few revisions on my AC joints, but I would say that they've all, quote, settled somewhat, and that's why we keep trying to look at this from a biomechanical standpoint in new ways that we can kind of stabilize that, because there's a tremendous amount of motion of that scapula that's out of the plane that we're actually fixing. So we thought when we first started the anatomic corticoclavicular ligament reconstruction that the conoid and trapezoid, based on Debsky's paper, would take care of a lot of that horizontal, because we knew we could get the superior inferior. But the issue really has been the fact that the protraction and retraction of the scapula, and it depends on how well the patient, like we talked about in the very beginning with the physical exam, can control their scapula. So those are all access of what's going to happen and how they do afterwards.
Well, it sounds like there's definitely more work to be done in the future, so I think we'll all stay tuned. Both of you this was awesome. I really appreciate both of you guys going through this. I mean, again, you both have such an incredible wealth of experience. That's about all the time we have for this podcast. Thank you so much to our guests. For all of our shoulder and elbow listeners out there, don't forget to subscribe, and we will see you next time.
Great job, Pete.
Thanks very much. Appreciate it, guys.